Okay, perfect. So we're going to talk about nerve blocks today. It's not going to be just ultrasound nerve blocks. This is the area of interest that I have, is just to, nerve blocks you can use every day to fix lacerations, reduce fractures, and things like that. So there's going to be a lot of expertise in the room. So we'll get everybody's input too, because everybody has its. There's no standard of doing this. Everybody has its own tricks of the trade and some pearls to share with you as well. Unfortunately, not making any money here, and so I have to come put my W's in every week. And we already said that I'm really good at this, art of procrastination, so I got up at 3 this morning to finish this talk off. But hard work often pays over time, but laziness always pays off now, right? So that's pretty good. So we're going to talk a little bit about the agents that we're going to use in local anesthesia, but also for these specialized regional blocks that we're going to discuss. And we're going to talk a little bit about basic regional blocks that I use in my practice every month, every week, and then get everybody's input on those. Which ones are beneficial, which ones do you believe in? And then we're going to do a little bit of introduction, more advanced blocks. And we're going to start with 3 basic ultrasound blocks. And saying that in May, there's a 4-hour on lecture schedule. It's a regional block workshop. And that time we'll review all the kind of blocks, do models, and have some phantoms as well. Okay? So let's start with the agents. So you have 2 major classes of local anesthetics. You have your amides and esters, right? There's multiple options here. I think for practical purposes, most of us have 2 agents that we use. There's 2 agents available in our emergency room here, and that's bupivacaine and lidocaine. Some characteristics in general that I think you need to know. One is the onset of action. So lidocaine typically in 5 minutes will get you numb, right? But it's only going to get you 30 to 60 minutes of worth. The benefit of bupivacaine takes a little longer, but it works much longer. So you have to know your agents and kind of what's useful about those. The other agent that you should be aware of is the tetracaine. The only reason for that is that very valuable solution that we have that comes in a little Phrygian minor. It's a combination of lidocaine, epinephrine, tetracaine with a cellulose gel. So the gel keeps it nice and local in the laceration, and then the medicine can start working. Both the lidocaine, the epinephrine, and then the tetracaine in there, I want to show you its property is high lipid potency. So it's going to, if you get it into that wound, inject it in, it's going to take that fatty tissue, it's just going to spread it nicely in that wound. And I'm really impressed by that solution. And you can fix a lot of lacerations just by using that. Remember the myth of epinephrine in fingers, toes, penises, noses, those things. I use this solution on all of those areas, and they work. That's a myth, and that really helps you to get away from needing to injection. The other thing to note about these agents is that allergies are very rare. It's usually a local reaction that causes, but if you do run into an allergy and you need an alternative, people describe Benadryl as alternative, so you can dilute a little Benadryl. You'll have to look this up. You're not going to remember this fact for that one patient. I've never had to use this. Anybody used Benadryl in a wound before? Cyril, of course, yeah. So people say it works okay, but you're probably not going to have to need to do with this, but you can potentially use that. So the other thing of note too is that all of these solutions you get an option, or these 2 major ones, to include with epinephrine. And so when you include epinephrine into the lidocaine formulation, 2, it does a couple of things. 1, it causes some vasoconstriction, so the agent hangs on a little longer. 2, you decrease bleeding, especially on the fingers and stuff. If you use it there, there's less need for like tourniquets and other forms of hemostasis. And the other great thing about it, there's a toxic level of max dose. And by using epinephrine, you can use a higher dose. So if you have multiple lacerations on a cutter and it's a small kilogram person, you want to use the epinephrine so you can use more of it in order to increase the maximum dose that you can use. So So I think that's important. A little bit of data out there about the use of bupivacaine, that it's probably superior to lidocaine. One, just acts much longer. But there's also some evidence that it probably has some of receptor downregulation and so forth, and also decreases even 48 hours later, significant less narcotic use later. So there's even some evidence. So I tend to use a combination of lidocaine plus bupivacaine. So you have a short-acting, short onset of action, but longer duration in the back. So you can use the combination. So that's useful. So you have both the benefits of both. Matt gave an excellent lecture on the myths in emergency medicine. So this again is one of those myths that you can probably throw out. Epinephrine is safe to use in digits, fingers especially. Hand injuries are common, and you can definitely use it. But you have to be sensible, right? You're not going to use it in a diabetic patient with peripheral vascular disease, or somebody with a vasculitis or lupus. It's going to be your healthy 20-year-old that's healthy, and you want to take off their nail or fix their complex laceration. You can use epinephrine there. It's going to be helpful. You don't need to tourniquet. The drug is going to last longer. Any questions about that? And just to reiterate, there's some data too behind this. Although if you look at recent Tintinelli Rosen editions, they're going to still say don't use it. Remember that's a myth, and you have data to support it as well. Here hand surgeons took 1,100 cases, and there was no complications, no gangrene. Everybody did well. Okay. What's the contraindications to use local anesthesia, and then in general a little bit blocks as well? Now, obviously, if the patient says they don't want it, that's obvious. Inability to cooperate is more in a sense when you're going to go to deeper structures, like you're going to do the femoral nerve, or you're going to do a median nerve, or you're going to do a plexus block. You want the patient's cooperation to be able to tell you, oh, that stings, that hurts, because that means you're in the nerve, and that's one of the complications that you're trying to avoid. You don't want to push the local anesthetic in a nerve. You want to be around the nerve. Does that make sense? So you want them to cooperate. And then this allergy, this is not very common. You do get people frequently say, I went to the dentist and I had a reaction. If you ask them, their heart sped up a little bit and they felt a little bit dizzy, that might just be inadvertent intraarterial collection, or that's just a side effect of the drug. That's not an allergy. Although there is urticaria, angioedema, and anaphylaxis described, but very rare. So you have to ask your patient what reaction they get. And you can always give a little test dose distally if you want to make sure. The other thing is you never want to really go through a site of infection. That makes sense. You don't want to take infection deeper into a tissue. And then if the patient is on Coumadin, Plavix, Pradaxa, those kind of drugs, you want to make sure that it's a compressible site before you do those blocks, and probably avoid it because a hematoma next to the nerve can cause lung compression on the nerve that can cause some problems. And you want to be also, when you first try out, don't go try it on diabetics who have some neuropathy, because your chances of injuring nerves are greater than they're more susceptible. And it will be hard to differentiate the injury from the injection versus the natural progression of the disease. Okay, everybody has tricks to reduce injection. I want to name a couple of things to how do you reduce the pain of injecting a local. What things can you do?
Bicarb.
Bicarb, okay. How would you use the bicarb? How do you typically do that?
So if you have like 10 cc syringe, you can use 1 cc.
Yes, bicarb.
And then the other halves, 2 halves could be bupivacaine and lidocaine.
Yes, so you use a 10%. You dilute it with 10%. So you take a little bicarb and 1 to 10 solution of either of the drug is good. So that's good. What else can you do?
Use a topical.
Yes, you can use a topical. So you can use that let before you inject, so let it sit a little bit, or just take the 4% lidocaine with a little Q-tip and just stick it there before you inject any mucosal surfaces. Any other things that you should do every time that you inject a wound or a laceration? Slowly, yeah. The faster you do it, the more painful it is. Anything else?
Go through the incision rather than through
that's helpful, yeah. Yep, good. Anything else?
Warm it up.
Yeah. So sometimes people keep lidocaine in the refrigerator. Ours is room temperature, but if you do refrigerate it, you do want to warm it up too. And of course, smaller needles is going to help to decrease it as well. So those are the common things that you can do. And then an error that I sometimes see novice people do, they inject intradermally, so they don't get deep enough. So they just almost give yourself a TB test. You raise that dermis up with the lidocaine. That is extremely uncomfortable. So you want to be in the subcutaneous tissue where the nerves are. Okay. Okay. So again, I think this is going to be on the boards. I think it's important for you to think about, not when you go fix that small laceration on the finger or on the face, but this is going to be when you think about it, when you have a large laceration, when you start using more than one vial. You have to think, am I going into a toxic range of these drugs? I think it's important to know. So what is the max dose of lidocaine?
Don't know the exact numbers, like 3 kids or something.
So that would be safe. So the max dose is 4.5 milligrams per kilogram. So I think this is one of those things you have to just know. You have to memorize it. You don't need to do it for bupivacaine, but lidocaine is going to show up on test questions and in your practice. Then if you add epinephrine, how can you extend that dose? 7 milligrams per kilogram. So that is important. You should know that. So how many milligrams is in 1% lidocaine per cc? Do you know how to make that formulation? Yeah. So it is 10 milligrams per cc. I don't think you should rely on your math skills to do this, because you have a very easy, okay, there's the maximum dose, because you have a very easy way to do it. You just look at the bottle. So 10 milligrams in every cc. So if you're going to inject 10 cc's into that patient, they are getting 100 milligrams, okay? So it used to be when I was in medical school that normal is 70 kilograms. I think we could probably safely say that it's now 100 kilogram individual. It's not a 70 kilograms, not normal anymore. So a 100 milligram individual will just get 1 milligram per kilogram. So you can give them 4 vials, okay? So, but that also makes it critical when you make a decision which vial to pick up. If you have multiple lacerations to fix, and you're going to know you're going to have multiple injection, don't go with the 2%, go with the 1%, because of the 2%, you're going to get into a toxic range much quicker. You're going to have double the concentration. Does that make sense? But a smaller wound makes sense to use the higher concentration. Okay? So, but think about it a little bit, about the side effects that people are always, when you do regional blocks, anesthesiologists come and say, oh, you should be prepared for this really bad complication of lidocaine associated toxicity and systemic toxicity. But think about it a little bit. If somebody comes in, they have a little VTAC. What is one of the options to give somebody in a VTAC? What drugs can you use? Lidocaine, right? How much? Yeah, so 1 milligram per kilogram. The vial, often a vial, has 100 milligrams. Just think about it. We take 100 milligrams in a vein and push it. And now you get a lot of flack because you get 10 cc's of lidocaine around a nerve. So that puts it in a little perspective that this medicine is safe. You can use it reliably. But you have to be careful not to get into veins.
What's your systemic toxicity in C?
Oh, we'll get to it.
and
so,
I think,
right there, right? Nice intro.
And I think you mentioned, I mean, you guys are thinking like, when would I ever give 4 mg per, 4.5 mg per kg, of lidocaine? I mean, 99.9% of the time, you never run into the problem. There are 2 settings. I mean, the beer block is one of them.
Yeah, I'm not going to discuss it. Go.
But and then which we could talk about afterwards. But it's with these large, complex lacerations where you do it, you can't close it, you need to call orthopedics or plastics in, and then they're going to give a little bit more, and then the lidocaine that you gave on the other side, that's already worn off, and you need to give a little bit more. So just keep in mind, especially like MBAs where there's glass shards and there's lacerations all over the place. That's where you're going to run into trouble. You need to keep tabs. Otherwise, you're never going to on arm lac, a linear laceration, you're never going to come close to it.
Or when it's a small person,
or
like
a small
anorexic
person, right.
person that's 50 kilograms that cut multiple times and you're going to inject all of those sites, you can get toxic there quick.
Do we ever worry about toxicity with the lead? Like if you use a large amount of lead over those people?
No. No, it has epinephrine in again, so the toxic dose is higher, but not with, you want to be sensible. You're not going to fix a big scalp laceration with just putting lead in there, so.
And we talked about using lido when you're topically anesthetizing someone for a scope, nasal scope, trunk scope. You're nasally intubating them. When you're doing the nebulized lido and all that topical stuff, it really doesn't absorb.
So Ray raised a good point. So now you do, say we have a hip fracture. We're putting 30 cc's of Marcaine on a grandma, and what do you need to look out for? How are you running into trouble? What symptoms do you get? What symptoms of toxicity are you familiar with? Ryan, are you familiar with any toxicity lidocaine?
Well, not really, but I guess if you give it for arrhythmia, then it maybe has the opposite effect, and you can get bradycardia.
Yeah, you could have circulatory collapse. That's right there. Well, what's the earliest things you can see? What's the earliest things people have seen or heard about? Yeah, so you can have that neurological symptom. You can have a little bit of tinnitus. You can have perioral numbness. People are going to feel tingly. You have to watch out for that. Okay, so that's your CNS symptoms. They're going to start early. These symptoms are metallic taste, lightheadedness, dizziness. If it progresses, they're going to go first in very excitation. They're going to seize in front of you, and then they're going to go in deep coma. So a spectrum of disease here, but you want to pick it up here early on and be sensitive to it, right? And it might be difficult, sometimes people are anxious, they have an injury, you're injecting them, they still remain anxious, they get a little hyperventilating, they get a little numb, so you have to be a clinician, but keep that in the back of your mind. Did you go intra-arterial? Did you use too much? Cardiovascular symptoms can be chest pain, shortness of breath, but you can also then get significant hypertension, syncope, and even cardiovascular collapse. You can get methemoglobinemia. It's much less common with bupivacaine, lidocaine, and the ones we commonly use, but it is associated with one that we used to use in the ER very often. Does anybody know what that used to be?
Hurricane or benzocaine?
Yeah, benzocaine, yeah. So hurricane spray. We used to use it all the time. When you scope somebody, you just spray their back of their throat very much. And so this formulation has the highest association of methemoglobinemia. So just keep in mind if a patient becomes cyanotic and gray, keep that in the back of your mind as a potential complication. Again, rare with the agents we're going to use for blocks in regional anesthesia. But if you do want to use this, keep that in mind. Another complication is allergies. We discussed that already. That's very rare. Okay, so let's move on. We'll start with some simple blocks.
So a quick question
Yes.
about the vasculosis again. If you have someone with amides being broken down, liver breakdown, do you have a different max dose for people who have severe liver disease?
No, I don't think so. I think it keeps the same. So this patient comes in. They have a complex laceration here. They have a fracture. They have a nail bed laceration. We're not going to get into specific should you repair that nail bed laceration, but this patient is anguished. They're very uncomfortable. What can you do? Ken, what would you do for this patient?
Probably do a finger block.
Okay. How do you do a finger block? What's your understanding of a finger block?
In terms of how to do it?
Yeah.
So it's been described to me several different ways.
Okay.
But the way that I've seen most people do it is they do it on the dorsal surface.
So you put the palm down. Yep.
Both sides at the base of the finger, kind of a straight down injection or straight down puncture, and then inject as you're withdrawing.
Okay, perfect.
And do that on both sides of the finger.
So that's your typical classical digital block. Everybody does that, right? So you go in, you have these two digital nerves that come into the finger. They are, if this is the upper part and this is the palmar surface right here, that you're coming in from the top with the needle and trying to get to the neurovascular bundle, laying local anesthetic right there, and then local anesthetic right there, and the two digital nerves are numb. Does this work every time? No. What's your success rate typically, Cyril, of doing? Do you do digital blocks like this, or do you? Or never, I'm not going to ask that question. Maybe you're going to give my punchline away, probably. How often does this work perfectly? Not all the time, right? You often have to go back, have to come and ring block them. And so I now use a technique that I think works 95% of the time. And it is also a form of a digital block, and it's called a thecal block. Has anybody used that? Flexor tendon sheet block. Anybody use that? I think this is the way to go if you want to numb up the finger, right? So you go on the palmar side of the finger. You identify the flexor tendon. You can easily feel it. You just go distally to this distal crease right there. Bevel of the needle up, 45 degrees, and you feel the needle going beautifully in the tendon. You try to inject, there should be very little resistance. It goes in that tendon and spreads beautifully. If there is little resistance, you should see the finger, as you easily inject, puff up immediately. You see that. It's really easy to see. If you don't see that, you should see the around the base of the finger just puff up. If you don't see that puff, go all the way into the bone, bevel up, come back 1 millimeter, inject again, and it works perfectly.
So you actually go further down. I mean, I usually go to the metacarpal head.
So
You go down to the
there's
palmar.
both.
Okay.
Both is
Okay.
described. Both is acceptable. This is what you see in the textbooks. I also go just over here as well. So, but the point is, you get into that flexor tendon. This works beautifully 95% of the time. So next time you do a digital block, try this. This works much easier. Not 2 injections, it's 1 injection. I can distract them. I hold their finger down like this, distract them with counterpoints, and it hurts a little bit, but just as the other, but it's 1 shot. It's only 3 mils, and it works perfect.
Is the needle actually going through the flexor tendon?
It's in the tendon. You want to get it into the tendon.
Okay.
You use the flexor tendon sheet to spread it.
So it's safe to go all the way down to hit bone?
Yes,
and hurt
often you have to hit the bone and come back a little bit.
Okay.
And remember, it's a small needle, 27 gauge needle, typically. This is not, going to be spinal 20 gauge needle. It's a small needle, doesn't do any damage. But this works really well, and I really like this.
So a couple of things I do, and sometimes I get incomplete anesthesia. It's happened once or twice. So a lot of times what I'll do is that 1 shot, go down 45 degrees, hit the bone, come back a little bit. And then a lot of times what I'll do is just kind of angle a little bit to the side, angle a little bit to the other side.
Combination of both.
And I do kind of a combination of both. So that's
All with 1 puncture.
all with 1 puncture. Yeah, I just pull back a little bit, angle that way, give it a half a cc or cc.
So for the old guys there in the back of the room, next time, try something new.
Renier, the way I learned from the hand guy,
Yeah.
they kind of pinch between the 2, and they use the back of the knuckle as the point. So they kind of put the index finger and thumb together, and that's where they will, inject it right there. Is that the way you do it?
Yeah,
Or-
yeah. You can feel that tendon very easily. If you run over that tendon sits on the bone. I run over there, bevel up, I go in. You can feel, it's like a lumbar puncture. When you go through skin, you go through something a little thicker. So you go in, you inject. If I struggle, it doesn't just puff up the finger very well. I go into the bone and come back 2 millimeters.
The only times that I don't do a digital block, and I don't know about you guys, the thumb and the big toe, I for some reason have a really hard time getting complete anesthesia using the metacarpal block.
Yes.
Do you use it on the thumb and the big and the great toe
no.
also?
For those, you have to really go.
Do a ring
and
block.
you have to do almost a nerve block. But definitely have to do both surfaces, palmar and volar, so to get the thumb and the greater toe numb.
We'll just put the foot totally flat, because I've done ICS, but they put the foot totally flat, and it goes straight down this way.
Into the webbing.
For the big toe.
Yeah. But it's wonderful. Okay, so John, you have this young kid coming in. They have a significant ear laceration here, and you want to fix this. What's your options to do this?
Can you do an auricular block?
Okay. How would you do that?
I'm not sure.
Okay. So that's a great idea. That's the point of this. You can, initially on what I do is I slap on a little bit of lap there. Gives a little pain relief there. Let it sift into the tissue. There's not a lot of fat here. It's going to take a while. But then I do auricular block. Now there is a very cool ultrasound block that is described where you block the nerve as it comes over the sternocleidoid muscle, the greater auricular nerve. But I've been looking for that nerve. I think it's challenging, so I think it's probably, you don't need to use ultrasound for everything, right? So, but if this is the ear, then what you're trying to then do is you're going to try to find this nerve that comes in about at this area. It comes in to supply this part of the ear here. Then you're going to try to get this greater auricular nerve that supplies this part here. And then you have a little bit of the lesser occipital nerve that comes here from the back that gets here to the back. And then you have a little bit of the cross coverage from this nerve that you have to get to the back. So typically what you do is you're going to go in underneath right here, going to do a shot. You're going to go all the way up here. And as you come back, you lay the local anesthetic down. Not removing the needle, you're just going to flip over your probe or flip over your direction, sorry. Yeah, there's all the other slides there. Okay, so you're going to flip over the needle without pulling it out of the skin, go all the way into there, and as you come out, you inject. Then you're going to do the same at the top. You're going to start somewhere here, go in here, inject, same spot, go all the way back here, cross the other side, and inject. And this works really well. It's an easy block to do, and your patient gets significant relief. You can do a lot of things, not lacerations, but if you have to drain a cauliflower or rugby ear, those kind of things, if you need to do any anesthesia, that you do. It will not get the external ear canal, so it's not a way to remove foreign body or something. You're not going to get benefit from there. Any questions about that? Very useful block. You can definitely use this in your practice. Okay, so somebody comes in, this person has a laceration here right on there above their eye, and this person has a laceration on their upper eyelid. So what options do you have to numb this up? We spoke about lead. Lead works really good in these. You let it put that gel in there, let it soak in there, and very often you don't need to do anything else. But if you want to do something, what can you potentially do? Nick, what did you do here? Supraorbital block. Yeah, so the supraorbital nerve is a very useful block. So it's called the supraorbital nerve, but what you really want to get the supraorbital nerve and the supratrochlear nerve. They both come out here, and you want to just inject above this entire space, and then you're going to get the upper eyelid too. Because, as you can see, that laceration on the upper eyelid would be very difficult to inject into to get that numb. It might be difficult to keep the lat on there, but if you could do a block above here, you're going to be able to have your landmarks clearly visible, be able to do fine work without losing or distorting landmarks by having a lot of lidocaine in there, and potentially putting the needle into somebody's eye is probably also not a good idea. So this is the aim that you're going to do through, and so what you're going to try to do is you just come in from the side with the needle, go all the way to the outer part of the eyebrow with the needle, and as you come back, you're just going to slowly inject the spread of lidocaine all the way. Put a nice generous amount of lidocaine there, wait a little bit, and you're going to have this entire forehead on one side done. If you need to do, if you have a midline laceration repair, you can do the same on the other side. Remember that all these facial lacerations, it's very crucial to get those skin markings, those dimples, all those things perfectly lined up. Put local anesthesia in it, it just swells up, and it's very difficult to get those margins beautifully lined up as you want the patient to look afterwards. Okay, how about this patient? He comes in with a lip laceration. Ryan, what can you do for this patient?
Is that infranasal?
Yeah, it's called the infraorbital nerve block. This is my favorite block of all ones. That really works well, and you can fix the lacerations very well. So the infraorbital nerve supplies this whole area, but also importantly the upper part of the lip. And I think this is the reason I like this block very well. When you fix a lip laceration that's through and through, mucosa to skin, what's the first stitch you should place? What's the most important things when repairing these lacerations? What's the pull there? Meridian border. What happens when you inject lidocaine and epinephrine in tissue besides distorting the landmarks? It often makes it, because it's very vascular, so it often creates blanching. Then you just can't always see that border very well. The border kind of disappears. So besides just distorting the landmarks, you can also make the border very difficult to see. So because that first stitch is absolutely crucial, that border has to be perfect. You want it to be nicely numb and not distort your landmark. So this is a great block to use. Again, what you do is you just lift up the lip, go here over this premolar junction here, and you can put a little Q-tip with 4% lidocaine jelly or a little lat right there. And then you're going to basically just take the needle and aim towards this little ridge that you feel. You're going to try to just go all the way to the ridge there a little bit, and then slowly come back 3-4 cc's, and that really gets a lip perfectly numb, and the injection is not that uncomfortable, painful. Anybody use this? Yeah, this is a great technique to use, and should use it often.
So do you have like an aim point? Like, are you aiming to the lateral?
So you want to just miss the lateral part of the nose and go towards the eye. So you want to go in through that premolar towards the eye, and just missing this edge. And you're going to try to hit this ridge here.
Okay, so you're kind of like aiming for right in the middle of the eye kind of area?
Yeah.
Mid-pupillary line.
But miss,
okay, right.
But miss the eye.
Yeah.
Okay, perfect. How about low lip laceration? Another no-brainer, So again, same characteristics. This is this stitch from here to here is the most crucial part, that vermilion border. Again, same reasons you don't want to store it. Here you can use the mental foramen of the nerve. You can block that going inside the mouth all the way to low to the chin area. You basically just open it up, retract the lip, advance the needle in front of the first and second premolar, and then aspirate and put some in it. This is really easy to do, and you can fix any lower part laceration very easy to do. So you should do that. Okay, you can describe Dr. Gessen's block to me. Can anybody describe it? Gessen block?
Back of the neck.
Well, it's, I guess it's when Gessen goes about evidence medicine, this is what I feel like, so I need a block. So no, this is a bad headache patient, and you want to do something. So I think this is a cool block. It's not actually named Gessen's block. It is a lower cervical intramuscular bupivacaine shot, and it's been studied. These are twins. One is a neurologist, one is an ER doctor. He's got great videos online about doing a lot of procedures here, and they studied it, and this was pretty good actually. And so complete headache relief in 65% of the patients, and partial headache relief in 20% of the patients. So I think it has a role. How do you do this? You're going to palpate the back of the spine. You're going to find the prominent C7 spinous process, and just above it, on both sides of it, you feel the bulk of the muscle, and you're going to go perpendicular. You don't want to point the needle downwards towards the apex of the lung. You want to just stay perpendicular to the ground. You're going to take just a short 1.5 inch 25 gauge needle with one. So you typically do pull up, and I typically take 3 cc's, and I'm going to do 1.5 on each side, so you clean the area. And look at this CAT scan. There's nothing you can hurt here. This is the level, right? This is less than 3 centimeters even. There's nothing here. If you go too far, what you're going to hit bone. There's no vascular structures here. There's no big nerves, nothing. You can't hit anything back there. So how does this work? Only Gessen knows. I don't know. I don't know what you numb up, but it works. And it's also been described for oral pain. Throbbing oral pain that you just can't get rid of. People get significant relief with this.
When they get that about 63% pain improvement, what kind of headaches are they? I mean, all comers, migraines, and
so widespread continuum of headache classification. So they used the patient was 771, just a retrospective review of patients with migraine or headaches, just classified headaches. Yeah. not specifically migraines. No.
Yeah, apparently works for oromaxillofacial pain. I mean, it's trigeminal neuralgia, it's been described,
Yeah.
it's been migraines, tension headaches, jaw
But the point
pain.
is, there's nothing to injure. It doesn't take you much time. And if there's a placebo effect, you know how some of these patients really can ruin your day. So if there's something you could do for them to make their transition smooth, and this is described 30 minutes, 65% of them have complete relief. Something to try. Okay, so Gessen's block.
Doesn't contain Dilaudid.
Yeah, no Dilaudid. They'll come back to you for bupivacaine.
Ray, what's the distance between your C7 Spanish process to the injection side? There's like a
Just 1 centimeter next to it. Just
1
1 centimeter next to it. Yeah, just in the bulk of the muscle, just next to it. So you want to basically put the drug right there and right there.
So there's no nerves running through there or anything, or nothing?
No, not at that depth. You know, don't use a spinal needle. You might get a vagal nerve.
You go on the full 1.5 inch in?
You go all the 1.5 inch in, all the way. You bevel this one, all the way in. Okay. How about dental pain? What do you have options for dental pain here? So this is a cool block, inferior alveolar block. It's for the bottom of the teeth. It's very common. You should use this. This works really well. You open your mouth, hand with the mouth, put it on the ramus if you want to feel inside yourself, so you can feel that little bone, and you're going to come with the needle next to it and go into your hip bone, come out 1 millimeter and inject, and you're going to cover all these bottom teeth on that side. It's going to have total anesthesia relief. So those patients that have legitimate pain, that you want to really give a good 200 minutes of pain relief, kind of break that pain cycle, this is something really good to use. And again, just to review, you're aiming to get right here on the medial side of this mandible right here. And so you're going to put your thumb right here so you know you're on the bone, and you're going to put the needle right here on the medial side from the back of this molar. Hit the bone, come back a little bit, and inject. So, does that make sense? Go try this next time. You need to do a couple for this to work. This is really good. Don't stick your fingers. You know, we have dental syringes, but really one of those just syringes where you could put your thumb into, you have full control over. That's all you need for any of these procedures. So that's a good to do. Now, the maxillary teeth are difficult. There's not a real one nerve that you can do, but there is the tooth block that you can do. So you've got one tooth here at the front of the upper teeth that's painful. You can numb up just that tooth. And this is called the tooth block, or we also call it the supraperiosteal injection. So you just go and just above where that tooth is, and you just inject all the way till you hit the bone at the base. Come back a little bit and aspirate and inject, and it will numb up that particular tooth fully. So that's an option if you have to do something to the tooth or put it back or just provide pain relief. Okay. So you're about to put a chest tube in somebody. Besides the local anesthesia that you can provide, is there something else that you can do to help your procedure go smoother? So this is not your trauma, unstable patient, cut and put the tube in. This is like patient stable, secondary pneumothorax that you want to put a chest tube in. Something you can do? Does anybody do anything else just besides just a lot of local in there? So one thing you can do, try to do, and this works well, I do use this too sometimes when I put Thoravent in too, is you just trace back that rib. So you remember that your neurovascular bundle is underneath the rib. That's why you go over rib when you insert a chest tube or any other tube, so you don't injure that bundle, especially the artery. But say for instance you're going to put a Thoravent here at the front or a chest tube here on the side, you could just go a little bit backwards, trace that rib backwards, and underneath the rib on the top side, I usually cover 2 ribs. You just put a little Marcaine right underneath each rib. See that? You just put a needle right past the rib, put the Marcaine in there, put the Marcaine in there, and then you technically should have no discomfort where you're going to put that chest tube in. So it does help for those kind of urgent but not emergent test tubes where you have to do some work. This also will help for pain as well. I won't do it for rib fracture pain because you have a chance of causing a pneumothorax. But if you're going to put a chest tube in, then that's good. Now there is a paraspinal posterior block that you can do as well. This is a little bit more risky because you can do this, and so we'll discuss it on our ultrasound guided blocks in next month.
You do that for thorovents too?
Yeah. And for thorovents, what I do too, if I numb it up, if you go there locally, raise the wheel, I just aim towards where the nerve is coming from as well. So I take the needle a little bit to the side, aim upwards, and so trying to get that intercostal nerve. Does that make sense? Okay. So now we're going to get to the 3 basic ultrasound blocks a little bit. There's a couple of other complications that we have to think about with blocks that you have to know about so you don't make these mistakes. And one is the nerve injury. Again, it's rare. Most of the time it happens when you actually inject medicine into the nerve itself. That's when you're going to cause trouble. So you can minimize this complication by stop. The patient says, "Oh, that hurts." It's usually a shooting pain. Stop. Don't inject anymore. Come back. Reassess where you are. Okay. If it feels like there's high pressure, remember you're filling a potential space around the nerve. It should just free flow of the medicine. If you feel pressure, you're probably in a nerve and you should pull out. You're going to cause injury. The other thing is you can look under ultrasound guidance. The spread of the lidocaine occur around the nerve. That's going to be useful. And this is where I think there's a lot of use for the long axis technique. Remember that when you do a short axis technique of any vascular structure, your most common complication or error people are going to make is they lose sight of the tip of the needle, and the needle is deeper what they think they are, right? So you think that you see needle on the screen, but the tip is actually deeper than what it appears because you didn't keep track of the tip. So, because nerve injuries can occur, if you lose track. But sometimes it's difficult if you do a block here around the Achilles, between the Achilles tendon and the medial malleolus. It's impossible to get a long axis approach in there. You have to just do a short axis approach. Hematomas, just be careful. We spoke about this a little bit earlier. We spoke a little bit about the local anesthetic systemic toxicity. Remember, this is one of those antidotes that you need to remember. It's very rare, so it's something that you probably have to know that it's available and know what the dose is, and you'll see it on. But if somebody becomes hemodynamically unstable, it's supportive therapy first. Stop the seizure with benzo and order this. It's fat soluble, most of these. So you put the fat in and it pulls that lidocaine out of the system, binds to the fat. Does that make sense? So allergic reaction, infection. This is good to know too, that a single shot peripheral nerve block, there's no reported infection, deeper seated infection. These infections do occur if you do put in, leave catheters in place longer, but a single shot block that we're going to use, no risk of infection. Okay, so let's, for the sake of this, let's move on just a little bit. So just to review a little bit anatomy here of what we're looking for, right? So you have your subcutaneous tissue here, so dermis tissue here. You have your subcutaneous tissue here. You have a little muscle belly, and in the muscle belly you have a hyperechoic structure that is a tendon. Then you have fascial planes that you can see here. Here is a radial artery here, and then right here is the nerve that forms this kind of honeycomb structure. So you have the outer layer of the nerve, and then the honeycomb structure of the nerve. And here is an example of a median nerve in the forearm where I'm putting lidocaine around this kind of nerve, and you're filling it up. So you can see that the lidocaine is not in the nerve, it's filling the potential space around it. So for a $5 coffee card is a specific artifact that you see with nerves. So you look at a screen and the nerve is gone. But you know the nerve is actually there. What is that artifact called?
All clear. Please return to normal procedures.
Okay.
May I have your attention,
Great,
please?
I have some more coffee
Customers
then.
and all clear.
So it's
Please return to
anisotropy,
normal
so we're going to
procedures.
discuss that a little bit.
May I have your attention?
Here is just the, you can see the needle tip right there, and you can see how we're just injecting around this nerve here a little bit. So just an example again of the different structures here. We have bone, we have radius bone right here. We have a radial nerve, radial artery right there. We have a muscle belly here. In the muscle belly, there's a tendon. Tendon can look like nerve, but as it goes into the muscle belly, it disappears. Here's the median nerve right here. It doesn't disappear into the muscle belly. It stays homogeneously the same. Nerves have this classical honeycomb structure. Here is the artifact that I was describing. See, there is a median nerve there, right there, but you can't see it. And then see that nerve right there, and then at some point it just disappears, and at some point it appears again. And so this is an artifact very classical to nerves, but also to tendons that you have to be aware of. It's called anisotropy. So here is an example of how this happens. So here is I am on the forearm, the median nerve transects here through the forearm here. At this level, the probe that I'm using is just slightly at an angle to that nerve. You see that probe is slightly tilted, so the nerve disappears. When I correct the probe to be totally perpendicular to that nerve, the nerve right there is bright, and it reappears. Does it see? You see that? Okay, so this is a common thing you have to be aware of. You can see it around biceps tendons or other tendons too. If you do a lot of shoulder ultrasound too, that if you are not entirely perpendicular to the tendon may look like it's gone or not there. Does that make sense? So when you shoot it, remember, because it's a high frequency beam with a small footprint. So if you aim that beam a little bit to the side, the beam doesn't return. The ultrasound machine says there's nothing there. Okay. So let's move on a little bit to one of the blocks that I would like to discuss, and this is the forearm block. We know that we can do this. It's easy to do. Minimal training. All blocks are successful. These nerves are easily to identify. The ulnar nerve and artery are with each other. The ulnar nerve is on the ulnar side. The radial nerve is on the radial side of the radial artery. Easy to find. And then the mid-forearm, if you just go between the two, you'll easily find a very bright median nerve in the middle. So whenever you're faced with a hand injury, think about this forearm block. You get 100% anesthesia. You don't distort your landmarks, and you can do multiple. Let's say the laceration is a dog bite as an example. Multiple lacerations, you can use this to your advantage. So if you just look up quickly which areas are covered, so you know that this laceration is mostly covered by the median nerve. So in this case, I'm just going to find that median nerve in the middle. I'm going to put that needle right next to it. You can see how it just fills up that space next to it, and as I put more in there, right all the way around that, I just put 10 cc's of lidocaine just around that median nerve. I'm going to have that $5 coffee that I have now, and then you come back, and that's totally numb to fix that hand. Does that make sense?
How
So
long
great
does it
block.
take to take effect?
It takes about 15 minutes, 15, 20 minutes. You know, sometimes, you know, you have to get it all the way around. You know, like most things, it takes practice. The more you do, the better you'll get. Okay.
Where in the corner, how distal are you?
So just in the mid-forearm, right here. Mid-forearm, right here.
And are you using bupivacaine, or are you using lidocaine, or?
So that's a great point. So I use bupivacaine, but initially when you start doing these blocks, bupivacaine is much more lipid soluble, right? So, and it's much more cardiac toxic. So because of the large volumes that you want to use, initially stick with just 1% lidocaine until you get much more proficient with these. Because you can use the lidocaine kind of to dissect through the tissue. I'm going to show you an example of that, and then, but you don't want to use that necessarily. Put that extra volume of bupivacaine in there. Okay. So how about this patient, Mr.
So are all your blocks in your arm then, I mean, you're going just here, or you're doing your, radial or ulnar blocks right at the wrist, or you?
I do that, yes. So the only caveat with that is, so as you come into the forearm, the ulnar nerve becomes very easily seen. That's very cool to see. The median nerve is beautiful to see right here in the middle of the forearm. The only caveat is the radial nerve sometimes remains very small. And so remember that the radial nerve has that interesting track that it does. Remember, you have a supracondylar fracture that you can injure the radial nerve. Why is that? Because it takes a track right here around to this side as it comes. Do you remember that from anatomy? So you can find the radial nerve right here, just putting your probe right there. There's no other nerves, arteries, nerves anywhere. Put your probe right here. You'll see that radial nerve beautifully big. You can numb it up there. Does that make sense? Okay, how about this guy? He misstepped some rocks. He got a laceration of the toe. He's got a deep puncture that has some foreign body in it. I want to remove that. How does people do with injections in the palm of their feet? Not very well, right? So it hurts like dickens, and it's very uncomfortable. And it's just difficult to inject, and it's difficult to get people numb by just locally injecting them. So this guy had the associated fracture here as well. So I wanted to really irrigate this very well and close it nice, and then remove the foreign body. So what block are we describing? Does anybody know?
Cyril.
Like a plantar
No. Hmm? No. One of those. You should probably. Yeah. So you use the tibial nerve block, right? So the tibial nerve will supply 90% of the foot. It's these, the green, pink, and the gray color. All of that is from the tibial nerve. The saphenous nerve and the sural nerve only supply a very small percentage of the foot. So you can get all that you're really going to see on the foot for lacerations with one nerve. Okay, so right here, just at the medial malleolus, just behind the medial malleolus, between the Achilles tendon, you have the nerve, artery, and vein sitting right there. This block, traditionally, if you use a landmark technique, doesn't work very often. It only works about 40% of the time. And the reason for that is that this nerve has a lot of anatomical variation associated with it. It doesn't sit next to the nerve artery. It often sits behind. And here's an example. Here is the medial malleolus, the Achilles tendon somewhere here. The probe, this represents that picture right there. You have the tibial artery right here. And instead of sitting next to it for a landmark approach, where's that nerve? Right behind it. And that's why the landmark approach, I'll throw it, why it's fallen out of favor. But if you use ultrasound, this is a very useful thing. Remember I said that you should use a long axis approach as much as possible. This is one of the blocks that a long axis approach is very difficult to do. So you want to come in with a short axis. And now you want to be careful because you're going to go past this artery. And so what can you do? Just as you go, use the local anesthetic as kind of a hydro dissection. So you put a little in that plane, see where you are. Find that needle tip is going to show nicely in that fluid. Find that needle tip, dissect a little further. So here's an example. So we're going to dissect a little further. See, I put the first little bit there. Okay, I'm next to the artery. There's the fluid, right? I want to get back there. So I'm going to advance a little bit more. There's my needle tip, but it's still not around there. So I'm going to go a little bit, and now I've dissected out that entire nerve there with lidocaine around it, and we had significant anesthesia. We were able to repair the laceration, remove the foreign body, wash things out, and no pain at all. Okay, so very useful block to use. Okay, anybody sees an old person comes in, what do they have here, Nick? What do they have? Hip fracture. Does everybody see this subtle intertrochanteric fracture? Yeah. But this person also has a very important sign that's positive. Does anybody know what this sign is called?
The Throckmorton.
Yeah,
Throckmorton. Yeah. This person has a hugely positive Throckmorton sign. So,
points to the injury.
does anybody
50%.
know what a Throckmorton sign is? So, of course, a British orthopedic doctor described that the penis points to the direction of unilateral disease, right? And the penis points to the fracture. So it turns out that somebody did study this retrospectively. It's not very sensitive, but it is specific. So, and the more sensitive sign is the negative Throckmorton, so that but anyway, that's this stuff. But anyway, this is a very positive Throckmorton sign. Okay, so what you can do for these elderly people that break is do a fascia iliaca block. You also hear about the 3-to-1 block or femoral block. I call all of this the same. Use one technique. Don't worry about all the other names to it. If you do one specific way, you'll get the 3-in-1 block and get good anesthesia. There is some research too here that was published here with ultrasound guided 3-in-1 femoral block versus opioids alone, and significant reduced pain intensity if you use this block. You needed much less analgesics and you had no adverse reactions. So it's a win-win, right? Usually the elderly that breaks their hips, they are do not do well with high doses of narcotics, so we can decrease some of that risk and help them out. Okay, so here is the example of just the important anatomy. So this is the left groin. So you have the femoral artery right there. You have the femoral vein right posterior to it. And does everybody see this big nerve here? And what's crucial about this block is that this is the fascia iliaca right here. So you guys see this bright plane? This bright plane, the nerve just sits right engulfed underneath it. The nerve doesn't communicate directly to the artery next to it. It's engulfed in this fascial plane. So often when this block fails, if somebody comes in from the side, puts the needle in here, lifts a wheel above this fascial plane, and that's not going to work. You're just not going to get any anesthesia there. So you want to go through this fascial plane here, this fascia iliaca, and once you're through it, you start raising a wheel. If you dissect through the tissue, you'll dissect a little fluid there, get a little closer to the nerve, dissect a little bit more with the fluid as you put it in there, and the nerve will sit beautifully there. And then you want to get all around it. You want to put 20 cc's of Marcaine in there, and it's going to work beautifully. It's going to have a 3-in-1 effect. But you have to get the important clue is you want to get past this fascial plane.
So you're doing, this is right in the inguinal area?
This is an inguinal area. So as you're just going to put the probe, so femur here, iliac crest here, linear probe. So you have your nerve, artery, vein. And so you're going to come in and you're going to inject the needle from the outside into the danger area. And you're going to dissect carefully with the fluid, get to the fascial plane, go through it, and dissect out the nerve with the fluid. Very easy to do. And you do many more risky procedures.
25.
Oh, so that's a good point. So this one is you're going to you're going to need to go a little deeper. So you're going to use a 20 or a 22 gauge spinal needle. Benefit of the spinal needle is twofold. One, it's longer. Two, its bevel is not, the cutting bevel of even the cutting spinal needle is a shorter bevel than a regular needle that we use to inject fluids with. So if you do get closer to the nerve, you have less of a cutting surface to cut.
You just use the spinal needle without the obturator? With the stuff on it?
Correct, definitely. Just the spinal needle, pull out the obturator, have the bigger syringe with your thumb, the thumb syringe, off the control syringe. Okay, so let's just as a review, remember that you.
Just one quick thing. So you use the fascial plane as your track, and you're going like along.
So your needle is going to come from the outside, right? It's going to navigate from outward to inwards, right? So you want to make sure that your needle goes through this fascial plane before
you're basically using it as your guide going.
Yes,
right
you
along.
have to be underneath it.
Oh, underneath it.
Yeah, underneath it. So sometimes if you inject a little bit, you see you're above it, then you can redirect the needle, come at a steeper angle, go through it, dissect a little bit with the fluid, leave a little fluid so you can get closer. Now, initially when you're very afraid, if you don't want to use any lidocaine, what you can do is you just take D5W and you can put as much D5W around that nerve as you want. Just put, D5W, and then when you feel like you can see that nerve beautifully and it's right there, then you come back with your marking and put it right in that big fluid pocket you just created.
How are you holding? So you're coming in from the side, right? And so how are you holding the probe so that you see the?
So it's a long axis approach. So they go inline axis. So your probe is like this, and your needle comes in like this underneath the probe.
Okay. Yeah.
Okay.
You sound like you're missing the tip as you're.
We're going to have a regional anesthesia workshop in the end of May, I think. So that's when we'll practice these and show you all the techniques. So more of the hands-on. Okay, so just a review. Know the drugs. Those are the two common drugs. Know that one, how fast they act, how long they last, and what those toxic doses are. Those are really important. You're going to see this again in a test. You're going to see it in practice. It's a drug you use. You should know what the limits of those drugs are. Think about deploying ultrasound for common blocks. High yield stuff initially, hand injuries. Practice these blocks. Get proficient here first before you go for the deeper blocks. We're going to discuss those other scalenus blocks and brachial plexus blocks and axillary nerve blocks. But that's line country. You don't want to go in there if you can't get this done, right? So, or as we say in South Africa, you don't piss against thunder, right? So, think about the use of the flexor tendon sheet block. The next time you work, use that thecal block or flexor tendon sheet block. And then when you do the face, think about it. Is there a nerve that you can just easily block? Don't distort the landmarks. Get to that quickly. Okay. And then this is a beautiful area in South Africa we went to visit. There's a big reserve out there. You can go see lions and out in the wild. But then in the middle part of the area, there's a nursery. And so this nursery, there was baby rhinos, cheetahs, lions. But this is a very rare white lion. This is a very rare lion that you find in Africa. It's a white lion. So kind of cool place to visit. You go there. It's just 45 minutes away from Barabon, so you can go have a nice trauma shift and then go watch some lions. Any questions?
When you do hematoma blocks for a fracture, you usually use lidocaine, or do you use a longer acting anesthetic?
Most of the time I do a combination. So you use the benefit of the two. So you have a little bit of epinephrine, a little bit of pivocaine, so you have faster onset but longer duration. Most of these procedures, though, you should. I guess the question also relates how fast are you going to do the reduction? Are you going to do it immediately, versus take some time? But yeah, the pivocaine lasts longer, so you might as well have that fracture pain reduction longer as well. And then Matt spoke about a beer block. That is.
I can bring it up briefly in a second. There's something that may come up on the board. So amides and esters. This is something that comes up. One of the little tricks that I was told to remember what is an amide versus an ester. Amide, I, has an I in it, right? So all of the amides have a second I in it, right? So amides, bupivacaine, lidocaine, mepivacaine, prilocaine, ropivacaine. It's important for a couple of reasons. There are individuals that the extremely rare allergy is generally to esters, right? And as Rainier mentioned, it's the metabolite that's a PABA metabolite. It is almost unheard of to have an allergy to the amide anesthetics. And it's actually not the anesthetic itself, it's the preservative. It's the methylparaben, which also gets metabolized to PABA that you could have a reaction to. So, somebody that says they have a quote-unquote reaction to lidocaine, it's generally the methylparaben preservative in the multi-dose vials. So what can you do to get rid of the methylparaben? Or what can you use instead of the multi-dose vials that does not have the methylparaben?
The single dose glass.
So those probably also have methylparaben in it because it probably comes from the same vat. But cardiac, I don't know specifically, cardiac lido specifically is single dose use, doesn't have methylparaben in it. That being said, somebody says they have an allergy to lidocaine, you're probably just going to stay away from the, the anesthetics altogether and do the Benadryl trick. It may come up on the boards though in terms of what's an ester, what's an amide, using cardiac lidocaine instead of the multi-dose vial lidocaine because of methylparaben. So just keep that in mind.
And one of the gurus of regional ultrasound blocks, Mike Stone, who's got a great ASEP lecture that's on his website. So if you go to Vimeo, do Mike Stone, his ASEP lectures are on there. But what he uses in conjunction with all these regional blocks is 10 to 20 milligrams of ketamine IV, plus the block. The block plus this, he said it can drain any abscess, reduce any fracture, do anything with that. So something to maybe add to your armamentarium as well. Okay, any other questions?
Again, so he does the block and also gives...
He gives ketamine before the block. 10 to 20 milligrams of ketamine does the block, and then the combination of the two.
This 10 to 20 and adult IV.
Correct, yeah. So it's pretty good. At Mayo, one of my friends there uses for all painful procedures, he uses 0.5 milligrams of kilogram. So it's pretty higher dose of ketamine for all patients with acute pain that he can't break. So he breaks the kind of pain symptom. He's pretty brags about the results that he gets, but we'll see how that goes.
I was going to get a plug for these blocks because, an 89-year-old lady who has a UTI and fell and hypertensive, you can't get narcotics because of their blood pressure. You don't want to, affect their breathing. It's not okay to let her go without. You have to treat the pain. She has a broken hip. And also in international medicine, you're seeing this being pushed more and more and more. Disaster scenarios, these scenarios, you're out in the wilderness, you don't have an IV, you can maybe just do a quick block or something.
No, that's great. I want to, reiterate that point. That's a great point because my friend in Wellington, New Zealand, a couple of years ago during the, it wasn't 10 years ago, right? Was it 10, right? When is the earthquake in Haiti? He went to volunteer, and there was no IV drugs for pain relief, but he had a sonosite and a lidocaine. So any person that needed a debridement, that needed a procedure, he found a way to block it. And so they had a procedure without IVs. They were doing amputations, washouts with just local anesthetics. So very useful for the austere environment. Yeah.
All right. Great.
Good.
Thank you. Just what the beer block. Does anybody?